I would like to introduce Dr. Adams, and she will talk to us about managing recurrence. Welcome.
Thank you so much, Tracy. Welcome, everyone. I'm going to talk about managing recurrence specifically for ovarian cancer for this talk, but some of the principles are broadly applicable. And Tracy and I agreed that we'll save questions till the end because I tend to get a little bit sidetracked with questions. So if you have questions, please put them in the chat and I'll do my best to answer them as we go through. As you heard, I'm at the University of New Mexico, so I try to put pictures of New Mexico in all of my talks because it's a beautiful place and I hope everyone will come visit. And we'll just go ahead and get started. These are my disclosures. As you've heard, I've been working with the Ovarian Cancer Research Alliance for many years, and I got my first grant ever from this organization. And I'm so delighted to be part of the conference again this year. Here's an outline of what we'll talk about today. We'll talk about what are the chances that ovarian cancer will come back after treatment. And I'd just like to acknowledge that this is a really hard topic. And so I'll do my best to work through your questions and I know that the rest of the conference has addressed a lot of questions that people have. We'll talk a little bit about what symptoms might suggest recurrent disease and how recurrence is diagnosed or confirmed. And then we'll talk about treatment options. And the theme of the talk today, I hope will be clear, is that there's a lot of options and there are more and more coming. And so there's a lot of enthusiasm about some of the new agents that are becoming available for the treatment of recurrent ovarian cancer. And then I know that there's dedicated sessions on clinical trials, but we'll talk briefly about clinical trials and how those might be a consideration as you think about treatment options for recurrence. And as I said, I know this is a hard topic sometimes, and I'll do my best to address the questions that we're able to address at the end. I also just wanted to clarify that, as you probably know, there are several different kinds of ovarian cancer. And I just wanted to say that most of the data we have is about epithelial ovarian cancer, and that's usually what people mean when they talk about ovarian cancer. But there are some rare subsets, germ cell tumors and sex cord stromal tumors, that behave a little bit differently and have some differences in the way that they're treated and the way that they are found clinically. And we can talk about those specifically if there are questions later on. And then among epithelial cancers, the majority of the cancers are serous cancers. There's some other subtypes, endometrioid, clear cell, and mucinous cancers. And sometimes those are treated a little bit differently as we understand better how they are genomically driven and how they might respond to different kinds of treatment. But most of the time when people are talking about ovarian cancer, we're talking about serous epithelial cancers. And just to orient all of us, and you probably know this, but usually primary treatment for ovarian cancer includes a combination of surgery and chemotherapy, either with surgery up front followed by chemotherapy, or sometimes and more often now, chemotherapy for a few cycles to try to shrink the tumor, make surgery safer, sandwiched with surgery in the middle, and then some more chemotherapy at the end. And we are very aggressive in our frontline treatment of ovarian cancer because we think this is our best chance to make a difference in patient outcomes. And so that's why we put people through this combination of very aggressive surgical debulking, trying to remove all of the visible disease in combination with cytotoxic chemotherapy. And now it's become very standard to use something called maintenance therapy, which is continuing treatment, usually with something that's less toxic than the frontline chemotherapeutics like carboplatin and Taxol. So the maintenance therapy is something like a PARP inhibitor, which is an oral agent, or sometimes we use Avastin, which is an IV agent, but is less likely to be associated with the kinds of side effects that are common with frontline chemotherapy. And so we can keep people on these agents for a long time, sometimes a couple of years, to try to increase the time before recurrence might show up. And so while people are on maintenance therapy, they're being seen for their infusions if they're getting Avastin, but if they're on a PARP inhibitor, they might be seen less and less frequently. And in some cases, people don't undergo maintenance therapy and instead transition into surveillance periods. And we keep an eye on them, usually every 3 months for the first couple of years. And if things are going well, those visits might space out to every 6 months. And sometimes we even get out to once a year visits if people have long periods of time without evidence of recurrence. But when we diagnose someone with ovarian cancer, we know that there's a high chance that the cancer might come back after treatment. And so I'll show you the data, and these are a little bit old, some of these figures, but the general experience is that most people who have ovarian cancer are diagnosed with advanced stage disease because, as you know, it's often asymptomatic until it's had a chance to spread beyond the ovaries and beyond the pelvis. And most people with advanced stage disease have experienced cancer recurrence at some point after treatment. And you can see the proportions here in this bar graph and the difference between optimally debulked patients, those who can have all of their tumor removed at surgery, and people who have disease that's unresectable at the time of surgery, who would be considered suboptimally debulked, and then stage 4 at the bottom. And so one of the things that I think is important to recognize is that the symptoms of ovarian cancer can vary. Um, and in general, we try to have a high level of I don't know, attention to people after a diagnosis of ovarian cancer. And we usually tell patients to call us if they have concerns about any new symptoms that seem to be persisting for a week or two. We can at least talk on the phone and decide if it's something that needs further attention or an exam or a workup. But classically, the kinds of symptoms we ask people about who've been treated for ovarian cancer are similar to the kinds of symptoms that you've seen outlined as being associated with initial diagnosis of ovarian cancer. And that includes bloating or abdominal fullness, new pelvic pain, changes in bowel or bladder habits, a feeling of fullness and not being able to eat a full meal. Sometimes people have vaginal bleeding. Sometimes they might have pelvic pain that might be evident during intercourse. Sometimes people develop leg swelling, shortness of breath, nausea, vomiting. Really, we tell people to please call us if they have these symptoms and they can't explain them and they seem to be persisting, as I said, longer than would be expected otherwise. And so when somebody has symptoms or when there's a concern about recurrence, we usually bring them into the office for an exam and then talk about doing imaging studies and some blood tests. And when we examine people, we're trying to find evidence of cancer recurrence that might be evident, on physical exam. And so we evaluate lymph nodes. We do a chest exam for the evidence of fluid around the lungs. We'll do an abdominal exam to look for fullness or masses. We do pelvic exams because it gives us an opportunity to see if there's any nodularity in the abdomen or pelvis that we can feel on a pelvic exam. And we evaluate for leg swelling, all the things that we usually do as part of the physical exam. Tracy, can you hear me? It just said I was muted.
I can hear you.
Okay, I don't know what, I'm getting messages popping up saying that I've been muted. So
Oh dear,
let me know if
sorry.
you suddenly can't hear me. Anyway, what I was saying is that because ovarian cancer often recurs in the abdominal cavity, it may recur in a place that we can't feel on physical exam. And so many people who have cancer recurrence may have a normal physical exam. So when we're worried, we'll use other tools to help us figure out if there's a cancer recurrence. And one of those tools, as you know, is biomarkers, and the most common one we use is CA-125, although some people are now using HE4 or some of the other combined markers to look for evidence of cancer recurrence in a blood test. And CA-125, as probably all of you know, is a very imperfect test because it can be high in a lot of different circumstances, like infection or inflammation. At the time of diagnosis, it's really not very helpful because it could be high with benign masses or malignant masses. But what I've found, at least in my practice, is it feels like kind of each individual has their own thermostat with CA-125, where some people CA-125 will go through the roof with very small changes in the amount of tumor that we find on CT scan. And other people CA-125 has a much more muted range and varies very little. But generally, if we have some idea of what the baseline level might be in somebody after she's completed treatment, and we see a rise in CA-125, that would be a reason for us to consider doing imaging studies to look for evidence of recurrence. And there's been some data suggesting that even a rise within the normal range, if it's higher than your normal baseline, might be something that's worth attending to with additional workup. And so often we'll end up doing imaging studies. And this is something that I know has come up in questions before. I use CT scans generally for people with ovarian cancer because most of our decisions are based on visible disease that we can see on a CT scan. And because a CT can be done to include the chest, which we can't evaluate with an MRI. But sometimes, okay, I'm hearing, okay, anyway, but sometimes people have a PET scan done for many reasons. And one of the questions that Tracy suggested that I address is when would we do a PET scan and when would we do a CT scan, and how can people decide which one is going to be most helpful for them in trying to find a recurrence. In general, as you probably know, with PET scans, people receive an infusion of a radio tracer, the sugar that's tagged so that we could see it on the scan. And so tissues that take up the sugar more rapidly look bright on the PET scan, and that can include tumor tissues, but it can also sometimes frustratingly include areas of inflammation. And so sometimes that extra brightness can be a little bit difficult to interpret. Um, and at least in my practice, I find it most helpful in people who previously had radiation, who might have residual scarred tumor that's not active, when we're trying to figure out if it's active cancer or just old scarred treated tumors. And since we don't treat ovarian cancer with radiation generally, I find that a CT scan is usually sufficient to let us know what's going on with disease burden. But there's reasons why someone might want to get a PET scan and why other providers might consider PET scans instead of a regular CT scan. And then sometimes, if we're not sure if what we're seeing might be a tumor recurrence, people will undergo biopsy so that we know for sure before we start treatment for recurrent disease. And so now we'll switch gears and talk about some treatment options for recurrent ovarian cancer. And again, I'll talk through a little bit of the philosophy about how we decide how to treat people, and then we'll talk about the specific agents. As I said, the frontline treatment for ovarian cancer is really very aggressive because we're hopeful that maximal effort in the frontline space will be very beneficial to people long term. In recurrent disease, there's a double consideration of trying to treat the tumor directly, but also trying to preserve someone's quality of life, because we don't want to treat them with something that makes them feel worse than they did previously, or that diminishes their quality of life overall. And so we're often balancing the potential side effects of treatment with the expected efficacy. And one of the things that can be most frustrating for patients and families, and for us also, for me certainly, is that we don't always know which treatment will be the best treatment for an individual patient. We know what the likelihood of response is among groups of people who are evaluated in clinical trials, but we don't often know for an individual sitting in front of us which treatment will be best for her. And so often these decisions are made based on someone's overall health, what kinds of side effects she had with the previous treatment regimen. Sometimes the schedule of treatment might weigh in, and overall expectations of clinical benefit, so how it might make someone feel, and what we are hoping to achieve with the treatment. But in general, as you know, the options include surgery, chemotherapy. We've got more targeted therapies now that we'll talk about. We'll talk a little bit about immune therapy, hormonal therapy. Radiation isn't used as often in ovarian cancer, but in certain cases may be. And then we'll talk, as I said, about clinical trial participation. To start, we know that surgery is extremely important in the initial treatment of ovarian cancer. And unlike other cancer types, we operate on people who have metastatic disease with ovarian cancer, because we know that getting out as much visible disease as possible has long-term benefit for people. The use of surgery in the setting of recurrence is a little bit more nuanced. In some cases, if someone has an isolated recurrence that's surgically accessible, surgery can be very helpful. And in some clinical trials, operating again has been shown to be beneficial. But sometimes in the setting of recurrent disease, it's not as clear that we'll be able to resect all of the tumor, depending on where the sites of recurrence are. And so it's very common for people to just move straight to chemotherapy. The other reason is we tend to find recurrence sooner than we find primary disease, because we're watching for it with these blood tests and exams and careful surveillance. And so often we catch it while it's still small, and so we can move straight to chemotherapy with the expectation of response. The other time when we might use surgery in the setting of recurrent disease is to address a specific problem, like a symptomatic tumor that might be causing bowel obstruction that we might be able to correct surgically. And that's a little bit of a different situation where the surgery is considered palliative as well as potentially therapeutic. Most of the time when we're treating recurrent disease, we use chemotherapy, and most people respond to chemotherapy in the recurrent setting. A lot of the information we get from the first round of treatment with frontline chemotherapy tells us what to expect with recurrent disease in terms of the effectiveness of the treatment that we have to offer. And some of that is about how big the tumor is and the distribution, as I said, whether it's in areas where we can resect it or whether it's in areas that are not safe to resect. But more importantly, we know that people who had prolonged benefit from chemotherapy the first time are more likely to respond to chemotherapy in the recurrent setting. And so that's a metric called treatment-free interval. And so basically the longer it's been since you've had treatment before you see recurrence, the more likely you're going to benefit from chemotherapy again. And that's been used to define a term called platinum sensitivity or platinum resistance, which is the amount of time since you were treated with a platinum chemotherapy agent, usually carboplatin or cisplatin, maybe oxaliplatin is the other one. And so we consider people to be platinum sensitive if more than 6 months has elapsed since she completed treatment with a platinum-based agent before we see evidence of recurrent disease, and platinum resistant if less than 6 months has elapsed. And in cases where people might progress during treatment with the platinum agent, we call that platinum refractory disease. And that tells us something about the overall aggressiveness of the tumor and the likelihood that it'll respond to other treatment options and really shapes our choices about what kinds of treatments to consider for a particular person. Here are some data, and these are a little bit old now, actually, but some of the foundational trials that helped us develop chemotherapy regimens for ovarian cancer. And these are all trials in patients who have platinum-sensitive recurrent ovarian cancer. And you can see what the response rates are across these different treatment regimens. These are all combinations of carboplatin with another drug, either Taxol, which is often used in the frontline setting as well, or gemcitabine or Doxil. And then you can see the addition of Avastin in the more recent trials. And you can see that the majority of patients do respond to chemotherapy in the recurrent setting who have platinum-sensitive disease, and that there's advantages to using 2 drugs over just carboplatin by itself. And then potentially additional benefit with the addition of Avastin at the bottom with the carboplatin, gemcitabine, and Avastin arm. And so this is the reason why we typically use a carboplatin doublet or even triplet with Avastin for patients with platinum-sensitive recurrent disease, as we see there's a high response rate associated with these regimens and the expectation that people will respond again to platinum if they did well the first time. And you can see the progression-free survival has increased over the years as these trials have been conducted, and that has continued to improve with additional agents that have been introduced for recurrent disease. In contrast, when people have platinum-resistant disease, the expectation that the chemotherapies that we have will be effective is a little bit more muted. And so this is showing some data from clinical trials with single-agent chemotherapy in the setting of platinum-resistant recurrent disease. And you can see that the response rates are lower, more in the range of 20% instead of 50 to 60%. And there's now some evidence that if we, again, pair these, add Avastin to some of the other chemotherapy agents, that there may be added benefit. But with the lesser expectation of benefit, there's really a much greater focus on what the side effects might be for a particular regimen, and balancing the expectation of benefit against these side effects that might be detrimental to somebody's quality of life, or making sure that we can support someone through a treatment regimen. Over the last now couple of decades, actually, but certainly in the last 10 years, there's been a surge of options to treat tumors with what are called targeted agents. And these are drugs that specifically traffic to a tumor with a particular cell surface protein on it, or particular type of tumor cell, with the expectation that there's less of an effect on your normal healthy cells, and so potentially fewer side effects associated with targeted agents. And so the advantages in general are that we hope that these have a more limited toxicity profile because they're not affecting healthy cells the same way that a nonspecific chemotherapy might. In most cases, we better understand the mechanism of action. And in many cases, these are active in the setting of chemotherapy-resistant disease. So some examples of this include Avastin. The other name for that is bevacizumab, which is a very commonly used agent in ovarian cancer. And as we've alluded to, it's often used in combination with chemotherapy agents. This is an antibody that blocks new blood vessel growth, so it starves tumors, prevents them from developing new blood vessels to supply them with sugar and oxygen. nutrients. And this has a high response rate by itself and also seems to augment the efficacy of chemotherapy agents, which is why we pair it in the recurrent setting. The poster child for targeted agents in ovarian cancer is the PARP inhibitors, which were initially understood to block DNA repair pathways and specifically to be very effective against BRCA deficient tumor cells, either people who have hereditary BRCA gene mutations or mutations just in their tumor called somatic mutations. And the reason is that the BRCA gene mutations disable one mechanism for DNA repair that cells rely on. And so the tumor cells that are missing that pathway are particularly sensitive to a drug that's blocking the alternative pathway for DNA repair. And so understanding this mechanism was extremely helpful in the development of this type of drug. And it's shown, as expected, extremely high response rates in people who have BRCA gene mutations or related mutations in their tumors in DNA repair pathways. And now, more recently, there's a new type of targeted therapy called an antibody drug conjugate, and we'll talk about that in a little more detail in a minute. But essentially, this is a way of leveraging the specificity of antibodies, which are proteins that your body makes to fight infections, that are designed to very specifically recognize, in the case of infections, a germ, some invading virus or bacteria. But these antibodies are designed to recognize tumor cells and to specifically deliver chemotherapy molecules just to the tumor cells, with the idea being that then you're directly treating the tumor and, again, less effect on the surrounding healthy tissues. So here's some data from one of the earlier PARP inhibitor trials that I think is important because it shows that in addition to having a large benefit in people with a BRCA gene mutation, these are Kaplan-Meier curves. So they're showing the proportion of people on the vertical axis and then time on the horizontal axis. And the diagonal lines show how many of the people that you started with still are without evidence of disease. And so the faster the curve goes down, the more rapidly people are seeing recurrence. And you can see on the left figure here that the patients who are getting niraparib, which is one of the PARP inhibitors, were much less likely to develop a recurrence over the time demonstrated here, which is 2 years, than the patients who are getting a placebo. But what's important here is that this benefit was also seen in people who did not have a BRCA gene mutation. And I bring this up because it's helpful to know that sometimes even these targeted agents may have benefits beyond the target population. And we've learned with PARP inhibitors that they may be effective even in people who do not have a BRCA gene mutation, opening up more treatment opportunities for a larger proportion of patients and informing our understanding about alternate mechanisms of action that might be contributing to the treatment benefit that we see in patients. So here's my slide about antibody drug conjugates. So we'll see if we can walk through this, but these are really exciting new targeted agents that have been introduced for ovarian cancer as well as for other tumor types. And there are a whole bunch more coming down the pipe. So, so we are very excited to have additional options for patients and very excited about the potential for these to be added to our current treatment armamentarium. Shown at the top right is an illustration of an antibody molecule. It kind of looks like the letter Y. And those branches at the top are the parts that recognize a target, like an infection as part of an immune response. And in this case, they're designed, as I said, to recognize a cell surface protein on tumor cells. And then the bottom end of the Y, the stem of the Y, is the part that usually binds to immune cells to engage an immune response. But in this case, has been replaced with a chemotherapy drug that can then be delivered directly to tumor cells. And the cartoon at the bottom shows an example with Elahere, which is the antibody drug conjugate that recognizes a protein called folate receptor alpha. The antibody binds to the folate receptor alpha. The antibody drug conjugate is brought into the cell, and along with the antibody comes that chemotherapy molecule, so that the chemotherapy molecule is in the tumor cell and destroys the tumor cell from the inside out. And now there's more evidence even that these can have bystander effects on neighboring cells that may express lower levels of the target. And so this has shown significant efficacy in platinum-resistant ovarian cancer and now has been approved for the treatment of platinum-resistant ovarian cancer and has been moved additionally into the platinum-sensitive space in some ongoing clinical trials. And this is not the only antibody drug conjugate. They all have names that are hard to pronounce, but there's trastuzumab, deruxtecan, and there's some others that are being developed. And so we feel very hopeful that this will give us an opportunity to help treat recurrent disease in a way that might spare people from the toxicities associated with chemotherapy that non-specifically affects all of the cells. I'll talk a little bit about immune therapy. I'll start off by saying that ovarian cancer was one of the first cancer types where we recognized the role of the immune system in controlling disease, which gave us a lot of hope that strategies to improve immune responses to tumor would be effective in ovarian cancer. Unfortunately, some of the characteristics of the tumors have meant that the benefit of immune therapy has been more muted than we expected. And so there's a lot of research being done now to try to figure out how to adapt immune therapy to benefit people with ovarian cancer. And right now, immune therapy is only approved in very specific cases for tumors with microsatellite instability, a very specific gene profile. But I'll talk through it briefly because we're hopeful that there'll be more options available for people with ovarian cancer in the upcoming years. In general, the goal of immune therapy is to alert your immune system to the tumor and to help your immune system kill tumor cells, and most importantly, to recognize tumor cells if there's ever a recurrence. So this is a really dynamic response that your body is able to mount. And we think that if we can direct it against cancer, we can clear the cancer that someone has and then hopefully reduce the risk of cancer recurrence with this ongoing surveillance by immune cells. And that's the long-term benefit that everybody's aiming for. As I said, it's currently available for ovarian cancer primarily just through clinical trials, but there are different types of immune therapy that you might hear about, and all of these have been developed and evaluated in ovarian cancer, including cancer vaccines, something called T-cell therapy, which is using T cells either from your own body, usually from your own body, that are genetically modified and then reinfused. And T cells are immune cells that are the killer cells that can kill tumor cells. And then some off-the-shelf approaches called immune checkpoint inhibitors. And these are the drugs that you have probably heard about. The names are pembrolizumab and atezolizumab and durvalumab. They are drugs that block inhibitory signals. People talk about them as ways of taking the brakes off of the T cells and allowing the immune response to better control cancer growth. This is a cartoon I showed to students about the immune response, and I just use it because I think it's helpful to understand the goals of these types of therapy. So bear with me, but in general, an antigen-presenting cell is a cell that detects something that's dangerous in your body, and it can then activate the T cells, which are the effector cells that can clear infected cells or tumor cells. And those T cells acquire cytotoxic capability, so they can go out and kill a tumor cell after this interaction. And the way I explain it to medical students is with a middle school analogy. So the antigen-presenting cells are like the informers that tell the T cell that there's something there to recognize, and the T cells are the enforcers that go out and take care of the problem. And I can't ever bring myself to label this little kid as the tumor, but you get the idea that this is the enforcer. And so when we think about immune therapy, the strategies are either to increase the amount of information that's provided to the immune system so that the T cells know what's going on better, or increase the number or the capability of the T cells to go out and kill tumor cells. And so one way to increase the information is with a tumor vaccine, which provides the immune system with information about cancer antigens or features of the cancer that might be recognized by the immune system. And the other way is to increase the number of T cells through T cell therapy by infusing more T cells into a person that specifically recognize tumor cells. Or as we talked about with those drugs that take the brakes off of the immune system and release the power of the T cells so that they can better recognize and control tumor growth. And so these are the overall goals of immune therapy, as I said, to elicit or boost an anti-tumor immune response, and hopefully to induce immune memory so that people have long-term benefit from treatment. And there's a lot of interest now in combining immune therapy with some of the other agents that we have, with the recognition that some of the drugs we've been using all along, even chemotherapy drugs, might work well together with immune therapy to really amplify the benefit of one or the other treatment by itself. Hormone therapy is another strategy for treating recurrent ovarian cancer. It's not usually the first approach that people use with recurrence, but it might be something that's used after someone's had several rounds of chemotherapy. And the reason for this is that hormone therapy tends to be very well tolerated. It doesn't tend to have the same side effects as chemotherapy. And so one way that I use it is if someone's still recovering from chemotherapy effects, like low blood counts or fatigue, but she has evidence of cancer progression and we need a new treatment, sometimes I'll use hormone therapy just to kind of hold things stable while she recovers from chemotherapy before we start a new chemotherapy regimen. There is some evidence that hormone therapy with agents like tamoxifen or fulvestrant can control ovarian cancer, but most of the benefit appears to be disease stabilization. And so that's why I sort of use it as a placeholder sometimes to, as I said, take a break from some of the side effects of more aggressive cytotoxic therapy. You can see the response rates listed here of these are selective estrogen receptor modulators, tamoxifen, fulvestrant, and then aromatase inhibitors, which block the production of estrogen. And these can be helpful in the setting of recurrent disease. I mentioned that radiation is effective in ovarian cancer, but very rarely used. And this is because ovarian cancer, as you know, tends to recur fairly widely in the abdominal cavity, and the toxicity associated with irradiating that large area in someone's body that has radiation sensitive organs like the bowel, the intestines, tends to be challenging. And so usually we use radiation therapy for specific recurrences, like someone has a lung metastasis that can be irradiated specifically instead of radiating their entire abdomen for treatment of recurrence. Also, if someone develops a brain metastasis, radiation can be very helpful for targeted therapy there. But it's not the first line approach for most recurrences. And then lastly, I put this in here and I try to force myself to talk about this when I talk to people about treatment options for recurrence. So these slides are partly to remind me to talk about, well, what happens if you don't start treatment when you find a recurrence? And this is now a pretty old study. It's from 2010, but it was a study that was done in Europe that really impacted my thinking, at least, about how to handle recurrent disease. And what the study did was it asked the question about whether it's best to start treatment early or wait until someone has symptoms from her recurrence before you start chemotherapy for recurrent disease. And in general, we all felt like starting sooner was important because we know that reducing the tumor burden with surgery is very helpful. We think that chemotherapy is more effective when there's not as much tumor burden. And we definitely want to catch a recurrence before someone's symptomatic from it and dealing with tumor symptoms to have better symptom control. But what this study did was it randomized participants into two groups, and one group was told about their CA-125 results when they had CA-125 tests, and that's that blood test we talked about earlier. And the other group was blinded to their CA-125 values. The idea being that the people who knew their CA-125 values would know when there was an increase in CA-125, which would be an early marker of recurrence, and they would start treatment in response to that. Whereas the other group would start treatment only if they had findings on a CT scan or on exam or new symptoms that led to a workup that found recurrence. And so the questions that were asked were both, how does this impact the amount of time that someone has off of treatment? How does it impact her overall survival? And how does it impact her quality of life? And what was, I think, probably shocking, it was shocking to me, was that there was no difference in overall survival in these two groups of patients. At least in this particular study, starting chemotherapy early versus starting chemotherapy later at the onset of symptoms did not seem to impact overall survival. What was also remarkable was that the people who were blinded to their CA-125, who started chemotherapy a little bit later, seemed to have better quality of life. And I think that's because they had fewer rounds of chemotherapy because they had more time before they started the chemotherapy. This is not, people have interpreted these data in several different ways. The recommendation in general from the Society of GYN Oncology is still to monitor CA-125 to consider treatment when a recurrence is found. But I do try to make sure that I have a conversation with people about, should we start now? Should we maybe just keep a close eye on things and do another CT scan in 2 months and see if things are staying stable? Maybe we want to delay treatment a little bit longer. Sometimes people have events coming up or other reasons why they want to postpone treatment. And we try to decide together whether it's important to start now or whether we might be able to see if we have a little bit more time off treatment to preserve someone's quality of life and to extend the treatment options that we have. All right. One more chapter and then we'll get to questions. So I'm going to talk now about clinical trials because clinical trials become a very important treatment option for a lot of people. And as a provider, I really appreciate having trials to offer people because it gives me more treatment options to consider for an individual patient. But I think it's really important to understand what the goals are of clinical trials if you're considering enrolling one so that you can ask questions about it and decide whether this is the right option for you. And also so you understand what some of the rules are and some of the design considerations are as a participant, so you know what your involvement will entail and know what to expect from the experience. So just as an overview, standard healthcare is the use of interventions that are designed just to enhance the well-being of the individual we're treating. These are FDA approved. These are our standard treatments for cancer. In the case of a clinical trial, there's multiple goals. This is testing a hypothesis and trying to develop new treatment options for the community of people with ovarian cancer. And there's always a hope that it will help the individual who's participating, but there's less known about what to expect about a clinical trial agent. And as we'll talk about, different trials are required to have different amounts of information about expected efficacy of agents. And I think that's important to know if this is something that you're considering. In general, some of the added benefits of clinical trial participation, in my opinion, are that there are a lot of people overseeing your care. These are highly regulated studies. There's a lot of oversight by institutional review boards, and in the case of national clinical trials, by national boards, the NIH or the GOG consortium or whatever agency is running the clinical trial. And so having all of those people overseeing the care of an individual to make sure that it's safe, to make sure that any side effects are handled appropriately, I think just adds to the support that's available to people. It's also very important to know that participation in a clinical trial is entirely voluntary and requires informed consent. So this requires that you're informed about potential benefits, risks, the schedule, what's required, and that you're assured that your cancer treatment will be provided whether or not you participate in the trial, that this is an entirely optional consideration. Other things that are important to talk about with clinical trials that come up are the process of randomization. So from a scientific standpoint, in order to be sure that a new treatment is really responsible for a benefit that might be observed or a toxicity that might emerge, sometimes larger trials are randomized. And that might mean that neither you nor your doctor knows what treatment you're on, or it may mean that you're randomized to a treatment and then you both know what treatment you're on. It depends a lot on the study design. And so you may enroll in a trial and be receiving something IV and not know whether there's an active drug included or whether it's just saline placebo. And sometimes that's disconcerting for people, but I do want to reassure everyone that it's not considered ethical to treat someone with cancer without an active agent. So usually the placebos are used as an add-on agent, just like the new drugs are an add-on to existing treatments in later stage trials. What that means is oftentimes the trial might be carboplatin and Taxol versus carboplatin Taxol and a new drug. So everybody's getting the carbo and the Taxol that we know works, and one group is getting the third drug to see if that has added benefit. That process of knowing or not knowing whether you're in a particular treatment group is called blinding. And that should all be very clearly outlined in the study protocol and explained to you before you agree to participate. Sometimes if people have progression, they might be unblinded, which means they might then be told which treatment they were receiving. And sometimes they're not told. It depends on the way the trial is designed. So here's the part that I think is important also is that different types of clinical trials have different goals. A phase 1 trial is usually a first-in-human trial, and this is developed based on data in cancer models, in animal models, and in cancer cells in a dish, demonstrating that a particular new drug seems to have activity, and that is sufficiently compelling that it's worth moving forward and advancing for treatment for patients. Because we don't yet know how people will respond to these agents, these trials are focused on toxicity to make sure that this is a safe agent to deliver to people, and then to try to figure out what dose might be tolerable in people. And so these might be just on the order of, 15 people. They're very small trials. They are not usually blinded or randomized because they're so small, and they're not usually with a control group. So everybody enrolling in the trial gets the new treatment regimen. And typically there's a lot of oversight and careful surveillance for toxicities because we want to make sure that we're keeping people safe while we're trying these new agents. And then once a dose is established in that phase 1 trial, we decide what particular dose is tolerable. The next phase of clinical research is to look for a signal for efficacy. So since these two different approaches to trials have different goals, they might also enroll different cohorts of patients. So it's not uncommon for phase 1 trials to enroll people with lots of different kinds of tumor. They might have stomach cancer and colon cancer and ovarian cancer. A lot of different tumor types might be included in a phase 1 trial because the toxicities might be similar across all of these people regardless of tumor type. But usually based on either preclinical data or a signal in phase 1 trial, once you move to phase 2 and you're looking for efficacy, those trials are typically focused on the type of tumor that's expected to benefit from a particular regimen. And so in phase 2 trials, there may be just that everybody gets the new treatment, or there may be some randomization with 2 different treatment groups for comparison. And these are a little bit larger, on the order of maybe 100 to 200 patients, sometimes even larger than that. And they may or may not be randomized depending on the size and the goals of the trial. But if you're enrolling in a phase 1 trial, you know that there's been some evidence of treatment benefit in cancer models, but not yet in people. If you're enrolling a phase 2 trial, you know that the drug has been determined to be safe to administer to people, and now we're trying to find out whether it's as effective as we expect it to be. And then when you get to a phase 3 trial, it's really kind of the confirmatory trial to demonstrate effectiveness in a particular disease site, and often to test whether the new agent is more effective than what we've been using already. And so these are the very large trials with hundreds of people in them that often have a control group of the existing standard of care treatment and may or may not have a placebo control, the kind of thing that we talked about with blinding, where you might get carbotaxel and an experimental drug or carbotaxel and a placebo and not know which arm you're in, to preserve the rigor of the study and make sure that any conclusions we draw are really based on the activity of that new drug. And so if you're enrolling in a phase 3 trial, you know that the experimental agent, the new therapy, has already demonstrated sufficient efficacy in a phase 2 trial to justify expansion to a much larger phase 3 trial to really see if it's even better than what we've been using all along. And then sometimes people talk about phase 4 trials. Those are post-marketing surveillance to see if there's any new side effects that show up when something's broadly available that didn't show up during a clinical trial. And so in my opinion, there's some advantages and disadvantages of participation in all of these different kinds of studies. If you're considering a phase 1 study, you're getting access to the newest, most cutting-edge treatment that's being introduced for clinical translation, but you don't yet have a lot of information about what that might, what benefit might be expected in patients. So there's a little bit more unknown along with the cutting-edge aspects of the new treatment. These are smaller studies. Usually results are available more quickly and, as I said, very carefully monitored for any signs of toxicity. Excuse me. The other thing about phase 1 trials is that sometimes the eligibility requirements for a phase 1 trial might be more broad. Just like I said, sometimes they're open to multiple different tumor types. They are often more lenient about how many prior treatments you might have had to qualify for participation in the trial. And so these are sometimes options for people who might not be eligible for some of the other available clinical trials. On the other end of the spectrum, a phase 3 trial is a much larger trial. There's more slots, more opportunity to participate. There's some evidence of efficacy that's already been established in phase 1 and phase 2 trials, so you can be reassured that something has been shown to be effective enough, as I said, to justify a much larger trial. But these are the ones that might be randomized and blinded, and some people are more or less comfortable about that piece of study design. And since these are so large, the results may not be available for a couple of years. But these are the trials that we hope will change treatment and will lead to approval of novel drugs as part of standard of care. And then, as we talked about, there are additional benefits with oversight by multiple teams of experts while you're participating in a clinical trial. As I said, it gives us more options to offer people for treatment. And then, of course, there's the altruistic component with benefit to other people who might have ovarian cancer by advancing the science and helping with the development of novel therapeutics for ovarian cancer or other tumor types. And so here are some questions you might want to consider asking if you're considering a clinical trial, and truly any question you have should be addressed before you consent for a clinical trial. But I think it's important to understand the rationale, why people think this might work, what phase of trial this is because of the differences we just talked about, to talk through the eligibility requirements, to understand who your contacts are if you have side effects that you'd like to discuss or report. I think it's also really important to understand the schedule because sometimes these trials require extra blood tests or extra visits, and sometimes that can be a barrier for people. Sometimes it's helpful to know who's sponsoring the trial and, of course, who the contact person is if you have concerns or questions as you think more about it. But truly, all of these questions and any other questions that you have should be addressed with the study team. And since this is voluntary, you can withdraw at any time. This is always considered an optional opportunity to participate in. And so we've talked about these already. These is my slide from last year that I forgot to take out because these are no longer just emerging. These are actually here, which is wonderful. We have antibody drug conjugates, as we talked about, that Y-shaped antibody and the targeted therapy. The immunotherapeutic strategies are still mostly in clinical trials, but I think they're coming. And there's some exciting new concepts that are moving into clinical trials for GYN cancers. And then, as I said, there is a lot of attention right now on combination regimens, trying to understand how to amplify the benefit of immune therapy in ovarian cancer by combining it with some of the agents that we already have available, as well as combinations between targeted agents and other cancer therapeutics. And so I think this is a really exciting and hopeful time for ovarian cancer treatment because we have so much more to offer people now than we did before. And what we have available has better efficacy than what we were using previously. And as the clinical research continues, I expect that that will continue to be the case. So this is White Sands. In summary, there are many options available to manage ovarian cancer recurrence. As we've talked about, the choice of agent is often individualized based on a person's experience with chemotherapy the first time, what kinds of side effects she might have had, whether she has residual side effects. Like sometimes people still have neuropathy that might be lingering from their first course of chemotherapy. And so you might not want to choose a drug that's likely to cause neuropathy again. Schedule, patient preference, travel time, all of these things. The overall goal always is to optimize quality of life and to prolong the time that someone has in remission. And then, of course, there's lots of information on the OCRA website about clinical trials and about ovarian cancer recurrence. And then I would be happy to, what time is it? I'd be happy to answer questions, Tracy. I don't know if you want to curate them, but we can go through some if we
Sure.
have a little bit of time.
Thank you, Dr. Adams. This was wonderful. And as you can imagine, there's lots of questions, but you answered many of them already.
Okay, good.
We've been busy bringing questions together, and
Okay.
you provided a really nice list of questions to think about for clinical trials, but we had 3 questions that came in around the same topic, which was, when do you consider a clinical trial? Is it right? And I apologize, everyone, I'm summarizing, but is it right after a first recurrence? Is it after many recurrences? What's the best plan?
That's an excellent question. And there's not one answer. So some trials are designed for frontline treatment, which means people who've never had treatment for ovarian cancer might be able to consider a trial. An example of one that's open now is called the HOT trial, and it stands for, I forget, hyperthermic, I don't remember, ovarian something, something, whatever the acronym is. But basically, it's evaluating hyperthermic intraperitoneal chemotherapy, HIPEC. And since that's given in the front line, that's a trial that's available to people who are newly diagnosed and would not be available to someone who has recurrent disease. In contrast, some of the trials, particularly phase 1 trials, are only offered to people after they've already had all of the treatments that we know work, because we want to give somebody something that we have some expectation will help her before we offer her something where we don't know what to expect from the phase 1 regimen. So there may be opportunities across someone's treatment course for clinical trial participation, and it's something to ask your provider about. Even at the time of new diagnosis, it may be an option for people. So it's not only after you've exhausted all of your options. In fact, sorry to go on, but some trials are specific for people with platinum sensitive recurrence. And so those are intended to be integrated early in someone's treatment, and you wouldn't want to miss the opportunity for a treatment that might be quite effective in a platinum sensitive recurrence by not considering a trial earlier in treatment.
Very helpful, thank you.
Sure.
And we had several questions around right after recurrence, first recurrence. Should you be tested for the folate receptor alpha? When should you be tested in? And going to tie in a second question, if you are not folate receptor alpha high, are there other ADCs available? I think you've answered that, but we had several questions.
So the answer to the first one about when should you be tested for biomarkers, I'm trying to catch up with the field and remember to check for these things earlier on, because these are now becoming options for people earlier in their treatment course. I'm a lousy cook, so I only think of things when I need the next agent or the next ingredient. And so I have been trying to make it part of my practice to start this testing earlier on, so that we know what options are available in advance, so that when we get to a point where we might need them, we can talk to people about what their options are. But truthfully, sometimes what happens is someone has a recurrence and we say, oh, shoot, we should check for folate receptor alpha to see if this is an option for you. And the answer about the antibody drug conjugates is yes, there's a lot of antibody drug conjugates that are coming down the pipe for ovarian cancer, to the point that one of the priorities for the National Ovarian Cancer Clinical Trial Committee through NRG has been to think about how to sequence these. And so you can tell me if this is too much information or not enough, but people talk about the target, what the antibody drug conjugate is recognizing on the tumor, and then the payload, which is the chemotherapy that it brings with it. And so you might have two antibody drug conjugates that both recognize the same target, but carry a different payload, so a different kind of chemotherapy is attached to them. Conversely, you might have antibody drug conjugates that recognize different targets but bring the same payload. And so the questions we're asking now, because we have so many of these, is how to sequence these. If someone has this antibody drug conjugate, what's the next best one to give her? And so it's exciting to think that we have so many now to consider, that we're thinking about how should we order them instead of just, thank goodness we have them. So many of them are available through clinical trials currently, but based on the success of the ones that have been introduced, I expect there'll be more options available soon.
It's very exciting. Thank you.
So too.
At what point do you determine if cancer is platinum sensitive or resistant? Is it the CT scan results or CA-125 rising? Like, what's your standard?
Often we'll use CT scan results, and to be fair, it's not like something magical happens at 6 months. This is a continuum. People recur, at 5 months and at 7 months. But the field has adopted this 6-month cutoff to divide patients into platinum sensitive and platinum resistant. And so, however you're defining recurrence, people call recurrence that's only found by CA-125 a biochemical recurrence. But usually we want to look for evidence of disease on a CT scan. And so usually, for example, for clinical trial purposes, we use the CT scan as the measure of when the recurrence was detected.
Thank you. And one other question regarding PARP inhibitors. If you are not BRCA positive or HRD negative, in a recurrent setting, can you use PARP?
Yes, there's some trials that have demonstrated benefit in the homologous recombination proficient, so the non-BRCA patients in the recurrent setting as maintenance, though the treatment indications for PARP inhibitors have been withdrawn. And so you may talk to your provider about whether this is an option to consider after chemotherapy for recurrence.
Thank you. We had several questions about, I've been on a PARP longer than 2 years, for 2 years, and now it's time to come off, but it's giving me comfort. Isn't there a way to stay on?
Yeah, so this is an active question in the field because we all like it too. We really, want people to do well for a long time. And so the NRG, which is the national consortium that runs clinical trials, that's funded by the National Institute of Health, is I think they're launching or they're developing a clinical trial to ask the question about whether there's added benefit to 2 years of a PARP inhibitor compared to 1 year of a PARP inhibitor, because nobody really knows how long is long enough, and conversely, whether long-term treatment might be causing some harm or some toxicity without additional benefit. And so to try to figure that out, they're running this clinical trial to see whether you get all of the benefit that you would get in the first year and you don't really need the second year of treatment, or whether the 2 years are important to keep the cancer under wraps. We know that a lot of providers, myself included, have continued to treat people with PARP inhibitors past the 2-year mark through shared decision-making about what are the toxicities that this particular person is experiencing, what are the potential risks of toxicity with long-term exposure, what other options might be available to her, and what her current disease burden might be.
Thank you.
Sure.
I know you answered the question around CT versus PET scan and what to do.
I answered it. It's hard to answer.
But
yeah.
we ended up having about another 6 to 8 questions all
Yeah,
around.
so I didn't answer it. Okay.
There's also, during the Ask the Expert session, there was the discussion around the newest CT machines and high resolution, and how effective they can be in millimeter slices, and maybe they're preferable over PET scan. And now there's some anxiety around scan anxiety, like where do you go and what's the right choice?
Yeah, man, it's really hard. And sometimes the technology outstrips our options too. So usually CTs, and I would defer to the experts you just had the panel with, but usually CT slices are taken at about 2 or 3 millimeter intervals. So there's this thought, well, what if there's a 2 millimeter tumor right in between the slices, the pictures you're taking? Maybe you would miss something. But I think it'll show up on the next scan if that's the case. And sometimes people's CA-125 will show us that something's going on. And maybe a 2 millimeter tumor that you can't even see is not causing symptoms. And maybe that's not the time to start a new cytotoxic therapy. So I kind of feel like these more sophisticated detection methods need to be matched by more effective treatments to really impact outcomes and quality of life. And so sometimes one is making more progress than the other. We need to catch up a little bit.
As you talk about quality of life, and we have time for just one last question, and you had talked a lot about having those conversations with your doctor, right? And we talk a lot about goals of care. Maybe there's an event, a party, a trip you're planning, having real intention around the next steps and goals. How do you encourage your patients, and what would you say to the participants watching to have those conversations?
I guess what I would say is I as I told you, I try to be very careful about making sure we talk about all of the things, all of the options, including what happens if you forego treatment or delay treatment. And sometimes that can be a hard conversation, but sometimes we just don't know what's happening with a tumor. Sometimes tumors grow really slowly, even in the recurrent setting. And sometimes tumors grow quickly, and nobody wants to miss an opportunity to control cancer growth. And so what I tell people is that if you decide to start treatment, you can always change your mind. It's not as though you say, I'd like to start treatment, and you're locked in for 6 cycles of a cytotoxic drug. If it makes you feel terrible, we can reconsider. Conversely, if you decide to postpone treatment, we can always reconsider that decision also, generally. And so what we'll often do is if people are interested in postponing treatment and they don't have a lot of tumor, and especially if it's not symptomatic and they feel fine, we might check again in 2 or 3 months instead of waiting 6 months, to look at a CT scan. And then we have 2 points in time. So we know that if in 3 months it went from here to here, then maybe we can wait 3 more months. And maybe this is a more indolent recurrence. Whereas if we check in 3 months, we probably aren't going to miss an opportunity to treat because that's short enough that we can then decide, oh, you know what, it's continuing to grow or it's becoming symptomatic. Let's change our plan. And the caveat is also, if you start to become symptomatic during that time, we would certainly change our plan. We wouldn't say, oh, we agreed to do the scan in 3 months, we've got to wait 2 more. We would say, oh, things are changing and we should adapt accordingly. So I like to keep things open in terms of how are you feeling now? How do you feel next month? How do you feel about waiting? Is the stress of waiting more bothersome than the idea of being on chemotherapy? Or do you have a wedding and a graduation and you want to enjoy these things off treatment and consider starting treatment after your plans? And as long as we can stay in touch and make sure that things aren't changing in the meantime, that seems like a safe approach.